Welcome back to Master Oral Pathology. Today, we're taking a deep dive into a really sneaky bacterial infection, actinomycosis. For you future dentists, this is a topic you absolutely have to master. Yeah, for your board exams, but more importantly, for your actual clinical practice. Recognizing these specific patterns, it can literally be the difference between a quick, easy resolution and a totally confusing, protracted clinical nightmare for your patient. Let's get into it. Right off the bat, let's talk about the name. Actinomycosis. It sounds exactly like a fungus, right? Mycosis is literally right there in the title. But here's the twist. It's actually a very specific and honestly deeply fascinating bacterial infection. It completely breaks the typical rules we associate with bacterial spread. Instead of a fast attack, it takes this chronic, slow-burning path. And that is exactly why it so often trips up clinicians who aren't paying close attention to the details.
Okay, so here's our game plan for today. We'll start with the etiology and pathogenesis, move into the clinical features you'll actually see in the chair, check out the histopathology, run through the differential diagnosis, and finally, wrap up with the treatment and prognosis.
Let's kick things off with the origin of the disease and how this thing actually starts. The crucial thing to understand here is that our primary culprit, Actinomyces israelii, isn't some exotic invader your patient picked up on a tropical vacation. No, it is a completely normal, everyday inhabitant of the human oral cavity. It's an anaerobic or microaerophilic, gram-positive bacterium. Now sure, on rare occasions you might see other species involved, but A. israelii, that is the classic, definitive, board-relevant organism you need to commit to memory right now. In a perfectly healthy patient, these bacteria are just hanging out, happily harboring right under our noses. You'll find them rusting in the tonsillar crypts, tucked safely away in gingival crevices, sitting inside deep carious lesions, or lingering in non-vital dental root canals. They are strictly opportunistic residents. They won't cause any issues at all as long as the host's mucosal barriers remain totally intact and undisturbed.
And that brings us perfectly to the pathogenesis. Because it's part of the normal oral flora, actinomycosis is not contagious. You can't catch it from someone coughing in your waiting room. Instead, it unfolds in 3 specific steps. Step 1. The bacteria are just existing normally. Step 2. Boom. A traumatic event happens. We're talking a tooth extraction, periodontal surgery, or maybe a severe mucosal injury. Step 3. That trauma essentially opens up an infection pathway, pushing those bacteria down into the deeper, oxygen-depleted connective tissues. And because they're anaerobic, they absolutely thrive in that low oxygen environment. That's when the disease firmly takes hold.
So, what does the scene of the crime actually look like when a suffering patient walks into your clinic? While you can technically find these infections in the thorax or abdomen, we are dental professionals, so our main focus is the head and neck. This specific presentation is known as cervicofacial actinomycosis. The mandible is a classic, super frequent target. Your patient is going to present with this massive swelling that, at first glance, simulates a standard pyogenic or pus-producing bacterial infection. But it doesn't stop. It relentlessly progresses, eventually forming multiple draining sinus tracts that burrow directly from the medullary spaces of the mandible, straight through the soft tissues, and ultimately out through the overlying skin of the face and neck.
Now, if there is one single diagnostic phrase you need to burn into your brain for the INBDE and for your daily clinical practice, it's this: woody hard. When you palpate these chronic indurated skin lesions, they have a classic woody hard consistency. I mean, it literally feels incredibly firm, almost board-like. This happens because the host's body is mounting this intense, walling off, fibrotic reaction against the persistent infection over a really long period of time.
And it gets even more distinct. If you look closely at the purulent discharge, the actual pus draining from those sinus tracts, you're going to spot these tiny, highly distinctive specks. We call them yellow sulfur granules. Now, a quick reality check, they aren't actually made of sulfur. That's just a clinical descriptive term for their yellow appearance. What they actually are: massive, dense aggregates of the Actinomyces israelii organisms themselves, clumped tightly together. Spotting these in the exudate is an absolute game changer for your diagnosis. Let's talk radiographs, because you absolutely should be taking them for these presentations. You're not going to find a perfectly well-corticated, innocent-looking cyst.
Nope. You'll notice a highly suspicious, ill-defined radiolucency with jagged, irregular margins. The aggressive bone destruction perfectly mirrors that relentless, burrowing nature of the soft tissue infection we just talked about. It looks frankly nasty, and it should immediately send your clinical suspicion through the roof.
All right, let's head to the pathology lab and see how this evidence builds up under the microscope.
Actually, before we look at the exact cellular data, let's test your own deductive reasoning. Based on everything we just discussed, the chronic nature of the disease, that dense woody fibrosis, the burrowing sinus tracts, what specific type of inflammatory response are we expecting to see here? Think about how the human immune system tries to handle a persistent, incredibly stubborn microscopic threat.
If you guessed a granulomatous inflammatory response, you hit the nail on the head. The body forms granulomas in this desperate attempt to wall off the spreading infection, which is exactly what gives us that intense fibrosis and woody clinical feel we felt earlier. Microscopically, you'll see this granulomatous tissue featuring a central abscess. And right there, sitting safely in the exact middle of that abscess, are those distinctive gram-positive bacterial colonies. Keep in mind, those microscopic central colonies are the exact same structures as those yellow sulfur granules we just talked about seeing clinically in the pus. What is truly fascinating here is the unique morphology of those colonies. Under the microscope, the bacteria form this unmistakable sunburst-like pattern. You'll literally see these radiating filaments with distinct, prominent clubbed ends right at the periphery of the colony. It's such a unique histologic presentation. When your oral pathologist sees those radiating gram-positive filaments with clubbed ends, the diagnosis of actinomycosis is basically confirmed on the spot.
Next up is the differential diagnosis lineup, where we have to separate our main suspect from its clinical lookalikes.
You've got to clinically distinguish actinomycosis from other severe conditions that present similarly. First up, osteomyelitis, caused by other bacteria or fungi. It also relentlessly destroys jawbone, but it usually lacks those specific sulfur granules and that sunburst radiating pattern. Then you need to rule out scrofula, which is a mycobacterial infection of the neck's soft tissues commonly tied to tuberculosis. Finally, consider botryomycosis. Despite the fungal-sounding name, that one is actually an unusual staphylococcal bacterial infection that can also produce chronic soft tissue lesions and granules. You really have to take your time and weight each of these against your patient's specific presentation. Here is a huge takeaway for you as future clinicians. The woody, hard swelling and the yellow sulfur granules, they give you a massive clinical suspicion. But you cannot make a definitive diagnosis on those clinical signs alone. Suspicion has to be weighed against absolute proof. You have to positively identify this specific actinomycotic organism in the lab before you lock in a long-term treatment plan. To get that definitive diagnosis, you need to go down one of three key avenues. Step 1 could be a direct examination of the exudate, hunting for those clumped organisms. Step 2, and this is super common, is a microscopic tissue evaluation. You do a direct biopsy, and the pathologist looks for those clubbed, radiating filaments. Step 3 is a full microbiologic culture. But a quick heads up, because these bacteria are strictly anaerobic, successfully culturing them in a highly oxygenated lab environment can sometimes be exceptionally tricky. That's exactly why a direct tissue biopsy is usually highly favored by practitioners. Finally, let's equip you with the knowledge to actually cure your patient. Treatment and prognosis. Look, this condition requires a highly aggressive, deeply long-term antibiotic regimen. Standard short-term antibiotics are simply not going to cut it against that fibrotic wall. The gold standard here is high-dose penicillin. For severe, deeply seated cases, patients start the acute phase with powerful intravenous penicillin to aggressively flood the system. Once that acute phase is managed, they transition into a very prolonged oral penicillin phase. Remember, managing this disease is a marathon, not a sprint. And just how long is that marathon? You absolutely need to know that this prolonged oral penicillin phase can last anywhere from several months up to an entire year. Yes, a full, continuous year of antibiotics for deep, chronic disease. Why so long? Well, that dense, woody, fibrotic tissue surrounding the infection makes it exceptionally difficult for drug molecules to penetrate the barrier and eradicate every last hidden colony of the bacteria. Now, of course, not everyone can take penicillin. For your penicillin-allergic patients, alternative antibiotics like tetracycline and erythromycin are highly effective cures. But honestly, medicine alone is often not enough. Direct surgical intervention is highly recommended. This includes physically draining the localized abscesses, doing a thorough surgical debridement of any necrotic jawbone, and completely excising that dense scar tissue and those burrowing sinus tracts. Why do we do this? Because physically removing that tissue actively aerates the infected area. Remember, These bacteria absolutely hate oxygen. Introducing oxygen while simultaneously removing physical barriers dramatically enhances the penetration and efficacy of your antibiotics into the remaining healthy tissues. So, future dentists, we have tracked this fascinating disease from start to finish. The next time a patient sits in your chair with a complex, woody, hard jaw swelling after a routine extraction, will you have the clinical foresight to hunt for those elusive sulfur granules? Will you instantly recall the granulomatous histology and that year-long treatment plan? Keep these concepts sharp, and you will be absolutely ready for the boards and for your patients. Thanks for joining me here on Master Oral Pathology. Keep studying hard, and we'll see you next time.